Thank you for joining us for today's event, Alzheimer's, Dementia, and Brain Health, What Everyone Should Know, presented by Kelly Osthoff, Senior Director of Programs at the Alzheimer's Association, Colorado. Today's event will be recorded, and all the registrants will receive an email with a link to the recording and any resources shared. At the end of this session and in the follow-up email, I'll be sharing a link to a survey. The State Library uses this survey to inform our work and to report on the value of our programming. Our presenter will leave some time for questions at the end of their presentation. If you ask your questions in the chat, we'll be sure to read them aloud so your questions are captured on the video recording for all viewers. And now to our presenter.
Thank you so much, Christy, for having me, and to all of you for joining this program today, either live or through the recording. My name is Kelly Osthoff, and my full-time role is I'm the Senior Director of Programs at the Alzheimer's Association of Colorado. Since I see people have come from all over Colorado, but also, goodness, I see Charleston, South Carolina in the chat, Indiana, Arizona. Please know that the Alzheimer's Association is a national nonprofit, and our hope certainly would be to engage with you and support you in your work, no matter where you are. Libraries certainly are such a vital partner in information sharing. And as I think the attendance today demonstrates, there's a lot of information to be shared about Alzheimer's and dementia. But in addition to my work at the Alzheimer's Association, I represent our cause, people with dementia, their care partners, and the future of Colorado on the Department of Public Health and Environment's coalition that we lovingly call ADDER-DAC, which stands for Alzheimer's Disease and Related Dementia Action Coalition. So this group, even though the Alzheimer's Association is national, this group is somewhat special to Colorado. In Colorado, we receive federal funding through the BOLD Act. The BOLD Act stands for Building Our Largest Dementia Infrastructure. So taking a public health approach to educate those who are living with dementia and their care partners, of course, and the professionals who support them, but all of Colorado on this topic. And I am the co-chairwoman with JJ Jordan to what is called our E-work group, which really, I think, boils down to our education work group. So Colorado is very fortunate to have this funding to expand the work that the Alzheimer's Association is already doing to ensure that whether someone is facing dementia now or will in the future receives information and education around dementia and Alzheimer's. So if you want to learn more about the BOLD funding that Colorado has and the state plan that this group of fabulous professionals has put together to address and equip ourselves around this topic in Colorado, I'll post that in the chat. So I'm kind of wearing a little bit of both hats today, the Alzheimer's Association, but also the chairwoman for a group that is CDPHE. But whether we are part of those groups or librarians, I really see us all as partners in this work. By training and education, I'm a gerontologist, which means I really take a look at aging across the lifespan. And so I hope that this presentation is helpful for you, whether you're currently facing dementia, or maybe you have concerns about yourself as you get older, a loved one. But to me, this is something that matters to all of us as we grow older, and we are growing older each and every day. We've entitled this presentation, Alzheimer's, Dementia, and Brain Health, What Everyone Should Know. So certainly this program will touch on a number of different topics, from a pretty bird's eye view. I'll try to dive into as much detail as I can in the time that we have together. But I welcome any questions that you might have in the chat or through audio after the program. But know that this is the start, hopefully, of our work with you. There's so much to know, and please know that we have additional programs, resources, etc., that may provide a deeper dive into some of these topics. I always like to start by painting the picture of why this matters. 10 years ago, 20 years ago, it may have been more rare that you would have met someone who knew someone with Alzheimer's or dementia. But probably what you're seeing today is it's actually rare to meet someone who has not been impacted. And so certainly this is a topic of growing concern. And that is represented by this prevalence data on the first slide. So I always like to start out with some statistics to create an evidence base of why this matters. We know that the number of Americans who are 65 and older living with Alzheimer's is expected to double by 2060. And you might think, oh my goodness, 2060 is so far away. But really, that's only 35 years in the future. And many of us will experience that year in our lifespan. You can see here on the graph that the millions of people ages 65 to 74, which is represented in the turquoise color, the millions of people ages 75 to 84, which is represented in the orange bar, and the millions of people represented in the purple color are certainly increasing decade by decade. Now, this is people over age 65. Arbitrarily, that's commonly the number that we look at when we talk about older adults. But in a little bit, I'll also talk about how Alzheimer's disease affects younger individuals. Many people, when they look at this graph, say, well, what is causing this increase in prevalence? So prevalence numbers are the amount of people living with Alzheimer's disease. In 2020, we estimated that that was about 6.1 million Americans. And again, by 2060, that number is expected to double to 13.8. We see the greatest increase in our purple group, so the group of people ages 85 and older. What causes this is a multifactorial combination of things, but the biggest cause is extended lifespan. People are living longer. It is more common that people are living into their 70s and 80s. And as we'll learn in a minute or two, age is the number one risk factor. And so as people are living longer, we are seeing greater incidence, meaning greater kind of proportion of that population having Alzheimer's or dementia. And you're probably wondering, well, what's the difference between Alzheimer's and dementia? Don't worry, I'll get to that. That's our FAQ, our frequently asked question. Now, in addition to those living with dementia, I also like to include a conversation of their care partners. So the family members, the family of choice, the neighbors, the unpaid caregivers who are supporting people with dementia. I always like to include a conversation of that community in this presentation. Alzheimer's dementia is what we refer to as a family system disease. Not only does it impact the person living with it, but it often acutely impacts those caring for that person. And so we estimate that in Colorado, so when we take that national figure that we saw on that last slide, and we boil that down to Colorado, we estimate that about 90,800 people in Colorado are living with Alzheimer's. But in addition to those people, their care partners are impacted by this condition. And we estimate that in Colorado, 177,000 people are providing unpaid care to people with dementia. So this figure includes people who are family members, family of choice, neighbors, who are not being compensated for their care. This number is not inclusive of paid caregivers, who are an important part of the workforce and the group of people supporting people with dementia. This is simply unpaid caregivers. If we were to have paid these people, and we would have equated how many hours of work that they would have given, it would be 307 million hours of unpaid care, valued at about $7.249 billion. We see that in Colorado, our older adult population will double by 2050. So we estimate that these numbers of people living with dementia and their care partners are gonna skyrocket in Colorado. What is concerning is that we need to make sure that we have a trained and skilled workforce to support this growing number of people. Now, in 2021, there were only 96 geriatricians in Colorado, and we expect that there's a pretty significant increase needed in this workforce of just physicians to meet the demand that we expect to see in 2050. I'm not going to dive into too many of the other numbers because if you're not a numbers person like I am, this might not be of interest to you. But the learning, I think, outcomes here are that not only are people living with dementia, but there are even more unpaid people caring for them. And we don't have the clinical and care profession to keep up, even with our existing number of people with dementia, but also as this number increases. And this data justifies why in Colorado we have this funding through the federal government, through CDPHE, through the BOLD Act to work on this state plan to address some of these challenges. Now, because I see so many people are from other states, I'm going to put a link in the chat where you can actually go and pull up your own state's fact sheet. So you can get the Illinois data fact sheet on this topic. As libraries are such an important part of information distribution, this would be something I think fabulous to have in the lobby that relates specifically to your state. Now, as we talk about the growing number of people with dementia and the why behind this, I mentioned that it is because people are living longer. We are treating chronic conditions and allowing people to live longer lives than in the past. And many people incorrectly assume that Alzheimer's disease is really genetic or really connected to family risk. What's important to know is age. Increasing age is the #1 risk factor for Alzheimer's disease. So as we grow older, which I would argue, even if we are under age 65, which is kind of that arbitrary cutoff, we are all at risk as we get older to develop Alzheimer's and dementia. Now, many people have historically incorrectly thought that Alzheimer's dementia was kind of a normal part of aging, that as you got older, people were supposed to develop dementia, supposed to develop Alzheimer's and become forgetful. But what we're learning is that people can age, live into their 60s, their 70s, their 80s without the cognitive impairment that is associated with dementia and Alzheimer's disease. Now, when we look at incidence within age group, we like to say that about over age 65, about 1 in 9 or 1 in 10 people have some form of Alzheimer's or dementia. But when we look at that number over age 85, it's about a third, or 34% of people over age 85 have Alzheimer's disease. So certainly that risk for disease or dementia symptoms increases as people get older. So age is the number one risk factor. Now, family history, genetics also play into that picture of risk. So we know that family history, meaning having a close family member, a sibling or a parent or a distant family member, a grandparent or maybe an aunt that has had the disease, we know that that family history increases risk as well. Additionally, there is some genetic risk to Alzheimer's disease in particular. And I'm happy to go into this kind of genetic risk in the Q&A. But simply put, there are kind of two types of genes that we know about with Alzheimer's. Risk genes, so genetic predisposition that simply increases our risk, our chance, our likelihood. And then deterministic genes, genes that if we have that gene, we will develop Alzheimer's. Now, if you're wondering about the latter, the deterministic genes, these deterministic genes, again, those genetic factors that guarantee someone almost to have Alzheimer's, these deterministic genes are very, very, very rare. They are ultimately and often the cause of younger onset Alzheimer's. And many people, most people with these type of deterministic genes know that they have this genetic status because a large proportion of them are involved in clinical studies. So don't worry after this presentation if you think, oh my goodness, maybe I have one of these deterministic genes that guarantees I have Alzheimer's. This type of gene, as it relates to Alzheimer's, is very, very rare. But there are risk genes that can increase our risk, that can make us risk neutral, or can actually lower our risk of disease. But anyone who is aging, who is living more each and every day, is at risk. And so age is the number one risk factor. And then family history and genetics play a part. But people without family history or without a genetic predisposition also are at risk. I know that throughout the years, people will learn what I do or who I work for, and they'll say, well, Alzheimer's is not in my family, so I'm good. And I simply say with empathy, I wish it were that simple, and I wish that could be true. Even people without a family history or without a genetic disposition can develop the disease. And we'll talk about other risk factors that may increase someone's risk, or we'll also talk about lifestyle interventions that we can all implement to lower our risk. It's critically important to note that certain populations of people have an elevated risk of developing Alzheimer's disease. Black and African Americans are about twice as likely as white Americans to have Alzheimer's or other dementia, and Hispanic Americans are about 1.5 times as likely to have the disease. A lot of research is happening in this space as to understand why. Why do communities of color carry additional burden in disease prevalence? And that work is certainly ongoing. We know that things like lack of access to healthcare across the lifespan might be a factor. Inequities across the lifespan might be a factor, but there's more to the story that they're trying to understand. What's also important to note is that when we look at the Alzheimer's research happening, communities of color and people of color are significantly underrepresented in these clinical studies. And so as we hear in the news and the news media that there's been advancements in Alzheimer's diagnostics, in treatments, Many of those diagnostic measures and treatments have been primarily tested on not only the white community, but white men. And so there is a significant need for communities of color to participate in research so that when we develop better diagnostic tools and treatment tools for Alzheimer's, that they are suitable for all communities. We also know that about 2/3 of Americans living with Alzheimer's are women. We know in my field that women have a longer life expectancy. Um, there's many reasons for that. Differing careers, differing lifestyle factors, but it is important to note that not only because women live longer are they at greater risk for this disease, but there's some other factors that the scientific and epidemiological community are looking at as well, such as possibly different exposures to educational opportunities across the lifespan. Historically, women may not have had as many of those educational opportunities as men. So that might be to be a cause of this higher proportion in women. It's also important for me to share that not only do communities of color and women have a higher incidence of a disease within group, but they also carry most of the caregiving, whether unpaid or paid, responsibility of Alzheimer's. Now, much of the data that I just presented was over age 65. I always laugh in my kind of field of gerontology that 65 has become this arbitrary kind of date at which someone turns from midlife to older adult. But we know that people are aging across all chronological ages. So while the data that I just presented related to people over age 65, I'd be remiss not to mention our younger onset Alzheimer's disease statistics and community. Some people may refer to this as early onset Alzheimer's. I like younger onset, which means that someone has started to show symptoms before age 65. Some people may show symptoms as early as their 40s or 50s. And we know that younger onset Alzheimer's is much less common and prevalent in the United States. We estimate that among the more than 6 million Americans living with Alzheimer's, it's kind of uncertain what slice of that is living with younger onset, but it is certainly much less common than what we call kind of typical Alzheimer's, whereas symptoms develop after age 65. People with younger onset face really unique challenges, often because they may still be raising a family, they may still be in the career force at the peak of their career, they may have a bucket list for retirement or life that they haven't even touched yet. And so they face really unique challenges in seeking a diagnosis, dealing with their finances, and managing the relationship changes that come with this disease. One of the challenges that has existed with Alzheimer's disease is it historically has been a rather challenging disease to diagnose. I'd be curious who in the room has had a family member, regardless of age, that they go to the doctor and the doctor says, well, you're getting forgetful. You've had this kind of odd experience where you keep losing things, you're getting lost going to the grocery store. But, that's just a part of getting older. And so ageism and kind of lack of understanding of the disease impacts people regardless of age, but acutely impacts those with younger onset. People often with younger onset Alzheimer's have a more frustrating and longer diagnostic process. And their symptoms, and we'll talk about kind of dementia symptoms in more detail in a minute, often are attributed to things like, well, you're at the height of your career, so you must be really stressed out. Or, you're going through menopause, and so possibly that's a cause. Or you have depression, and so that might be why you're becoming more forgetful. So younger onset Alzheimer's certainly is more challenging than later life Alzheimer's to diagnose. Okay, the question of the hour, I know what it is what is the difference between Alzheimer's and dementia? I even myself use these terms interchangeably, but their difference is very important. Dementia is an umbrella term for a variety of symptoms. So someone's dementia may include these symptoms, whereas another person's dementia may include this other set of symptoms. These symptoms range from memory loss to other changes and loss of ability in thinking and reasoning. And dementia is considered when these changes are severe enough to interfere with daily life. So, all of us on this call, I would argue, have misplaced something. I've misplaced my keys, right? So, we always think, oh, I'm sometimes forgetful. Does that mean I have dementia? I have the ability at this phase of my life to recall what I was doing last time I had my keys in order to retrace my steps to find them. So that memory lapse does not interfere with my ability to lead a daily life. Now, whereas it might become dementia is if someone is regularly losing their keys, misplacing them in very odd places, maybe every few weeks having to purchase a new set of keys for their car because they can't even find the old set. And it is so frequent and so prevalent that it interferes with their independence. So dementia is when these kind of set of symptoms, again, that are changes in memory, thinking, and learning, our cognitive skills, interfere with someone's daily life and impact their independence. So if dementia is a set of symptoms, it's important to understand that age alone does not cause these symptoms. Unfortunately, there are still medical professionals out there that will say, well, this person is in their 80s. Of course, they are experiencing these symptoms. And age alone is not a cause of dementia. People can age into their 80s with the symptoms of dementia and without. So it's important to recognize that there are a variety of diseases and conditions that cause dementia. Alzheimer's disease is the most common type, or what I like to say, cause of dementia. So Alzheimer's disease, when it is causing the dementia, Alzheimer's disease is what's happening in the brain. And dementia are the symptoms, the changes in thinking, learning, and memory that someone may be noticing. It's estimated that Alzheimer's disease, and I'll talk about kind of the unique pathology that is Alzheimer's disease in a minute. It's estimated that Alzheimer's disease causes about 60 to 80% of all dementia. So those two terms, I think, get interchanged very frequently because Alzheimer's disease is the most common cause. However, there are other causes to dementia that include vascular dementia, Lewy body disease, frontotemporal dementia, other diseases and conditions like Huntington's, and, for example, in my grandmother's case, mixed dementia, where the symptoms are caused by a variety of things. So in my grandma's case, she first experienced vascular dementia. So she had a series of heart attacks and cardiovascular issues that impacted her brain. And so some of her initial symptoms kind of looked like she had had a series of strokes. But then she also started developing kind of the hallmark symptoms of Alzheimer's disease. So some people have mixed dementia. Frontotemporal dementia is getting more and more recognition because it commonly is accompanied by aphasia. So loss in language abilities, particularly a very challenging ability to retrieve words. Recently, Bruce Willis has come out with having this symptom and consequently frontotemporal dementia. So this kind of raised awareness of that type or cause of dementia. Likewise, Lewy body dementia is getting more and more attention. It was believed that Robin Williams, who passed a number of years ago, started to have hallucinations, sleep disturbances, increase in his depression, that were believed to be caused by Lewy body disease. So a different disease than Alzheimer's causing those symptoms. Lewy body disease is often, but not always, associated with Parkinsonism. So there's a lot to be said and learned about on this topic. But what's important to know is that if someone is exhibiting the signs of dementia, changes in their memory, thinking, and learning, something else is happening in the body that is causing those things to take place. 60 to 80% of the time, it is Alzheimer's disease. It is a unique pathology, biology in the brain that we know as Alzheimer's disease. Now, with some symptoms of dementia, there are actually cases that are caused by things that are treatable. Not always, but occasionally. Someone may be mismanaging their medications. They may have sleep apnea that's untreated, unmanaged diabetes, depression that is unmanaged, alcohol abuse. There are kind of a variety of things that can cause someone to present as forgetful or having cognitive changes that in addressing that problem may kind of improve their cognition. And that is one of the reasons why we say dementia should never be a diagnosis. The question should be, okay, someone has the presence of dementia. We need to kind of dig into what's causing those symptoms. A little bit about Alzheimer's in particular. So Alzheimer's disease is a unique pathological, biological, meaning that there's a unique disease process happening in the brain that, because of where it starts in the brain and spreads in the brain, impacts people's memory, thinking, and behavior. Symptoms might be very subtle at first, but as the disease, so that pathological, biological disease, as that spreads throughout the brain, symptoms may become even more severe. We know that Alzheimer's disease is a progressive disease, meaning that that disease starts in a part of the brain, and as that disease element spreads throughout the brain, symptoms become more and more worse, or more and more severe, excuse me. So someone very early on may just struggle with word retrieval because that part of their brain is not working properly. Those neurons aren't firing as they should. But as the disease spreads throughout the brain and not only affects the neurons, but unfortunately causes neurons to die, they may lose short-term memory altogether, and they may even lose language ability and lose ability of other things as well. So in short, we know that in the very early stages, memory loss and challenges with thinking and reasoning is very mild. But as that disease progresses, someone in the later stages will need around-the-clock care because they will ultimately forget who they are, where they are, what they need to do to take care of themselves. And so they need around-the-clock 24/7 care to keep themselves safe. And that is why eventually this disease impacts the care partners and formal caregivers so much. So real quick, I'd like to just kind of give a visual image for those of us in the room who are more visual of what kind of a normal brain may look like. So this would be if the brain is kind of sliced this way, it's healthy. All the brain tissue, the white matter, the gray matter is there. The neurons, so the nerve cells that transmit messages in the brain are working, they're functional. But with Alzheimer's, because of where it starts in the brain, so where the disease elements start to develop, certain areas of the brain that are responsible for memory, thinking, and reasoning At first, those neurons start to not function, so the brain cells don't send that message to remember that story. But ultimately, we see neuron death and we see brain atrophy, so actually shrinkage of brain. What's interesting is that as we have understood this disease more in the scientific community, so that's kind of a collective we believe and know that Alzheimer's is a continuum. So what this means is that the scientific community that is using this information in research knows that there is actually a point in time when disease can be detected in the brain, but someone has no symptoms, meaning there is an asymptomatic phase where disease is present and can be detected with advancements in diagnostic measures, but they're cognitively functioning as normal at their baseline. And this is a game changer in the treatment landscape, because in other diseases like heart disease, we can identify an asymptomatic phase by the use of biomarkers. So when someone has elevated cholesterol, for example, but they don't yet have a heart attack or other cardiovascular issues, that's kind of what's considered an asymptomatic phase. So we're actually at a point in time with Alzheimer's, not in the general clinical setting at your family doctor or your neurologist, but certainly in the clinical study environment, where someone with no cognitive changes can, through a variety of diagnostic tests, be studied to say that they may have disease in the brain. And so we're thinking of Alzheimer's disease now as a continuum, from a phase where it's asymptomatic, so someone has disease in the brain with no symptoms. Clinicians now can detect what's called MCI, or mild cognitive impairment. So there might be kind of subtle changes in cognition, but it's not severe enough to be considered dementia. And then there's, along the continuum, how we've always kind of thought of Alzheimer's or dementia. Mild dementia, moderate dementia, or severe dementia. Early, middle, and late stage is what is used in the non-clinical setting. Now, I would say, especially if you had a loved one, a family member, or a chosen family member a few years ago, decade ago, that had Alzheimer's disease, it was more common that they were diagnosed at the end of the continuum. Their cognitive changes were so obvious that it was clear that it was Alzheimer's. And that leaves little room for interventions that may include care planning, end-of-life decision-making, and now, if someone chooses, pharmaceutical interventions. But with diagnostic improvements and kind of a general better understanding of Alzheimer's disease, people are being diagnosed earlier and earlier along the continuum, allowing them more time to have better cognition, to participate in end-of-life planning, do that bucket list, possibly take advantage of treatments if they so choose. And soon, there may be a time where there's an asymptomatic diagnosis. So someone may be diagnosed before cognitive changes because of disease presence. So to me, that's a really good differentiator between dementia symptoms, so the changes that you're observing in someone, and disease, Alzheimer's disease being the most common cause of dementia. Now, those of us on the call probably think, like the example I gave a bit ago of, oh my goodness, I misplaced my keys last week. And memory loss, or misplacing things, losing the ability to retrace steps, is just kind of one symptom of Alzheimer's disease. Here on the screen, we have our 10 common warning signs of Alzheimer's. Warning signs, I think, sounds so severe, and so I like to see these are kind of the common symptoms that we see with Alzheimer's disease. It not only includes memory loss that disrupts daily life, but it includes difficulty completing familiar tasks and challenges in planning or solving problems, like following a recipe, confusion with time or place, so getting lost, misplacing things and losing the ability to retrace steps, so being able to retrace the steps to get yourself home, new changes with words and speaking or writing. Many of you may think, well, I am horrible at names. Does this mean that I have one of these symptoms? Here we're talking about someone's baseline, what they've been able to do generally their whole life, and changes to that baseline. So if you've always been good with names and that all of a sudden becomes challenging, that's a change in your baseline. If you've never been good with names and you continue to not be good with names, that's really not a change in your baseline. But other things may include trouble understanding visual images and spatial relationships, which is why in one of the diagnostic tools to detect dementia symptoms, they ask you to draw a clock, a face clock, not what shows up on our phone, a face clock. So drawing a clock is our ability to put together images and numbers and shapes in relationship to one another to create something that is meaningful visually. So that is why if you've ever had a cognitive screening, they've asked you to draw a clock, because someone who could draw a clock at a certain time may struggle to do that. We also see decreased or poor judgment, withdraw from work or social activities, or changes in mood and personality. Everyone's different. Everyone's brain is different, and we all have different skills, abilities, and challenges. So it's very possible that someone may experience one of these symptoms very prominently, and because of intelligence or coping skills, they're able to kind of compensate for the other changes. So, for example, someone with a very large vocabulary might not have as many language issues, because when they lose the word for computer, they might be able to quickly compensate with screen. And so everyone is different. And it's not necessary for someone to experience all 10. So everyone is kind of different in how they experience these early symptoms. But if you're concerned about yourself or someone else, it's critically important to see a doctor. We recommend people start with their primary care physician, who can do some very basic cognitive testing to see what changes may or may not be happening. Now, it's important to pay attention to these changes and seek an early detection. And this is true in many disease spaces. You know, we've heard people who have survived cancer that because it was caught early, interventions allowed them to live longer or live a higher quality of life, or in the cancer space, even survive cancer. It's true that in dementia, early detection is very important because of what I said earlier on, that some causes of dementia are treatable, like sleep apnea that's untreated, depression, medication mismanagement, vitamin deficiency, etc. Or the causes to someone's cognitive changes aren't reversible, and it may be Alzheimer's disease. It may be frontotemporal dementia. But what allows this better quality of life with an early detection, it allows people to plan for their future, to participate in decisions that impact their future care, possibly get their legal and financial affairs in order if they don't have those things in order. Additionally, this is a rapidly changing time in the treatment landscape. There may be something in a few months that is available to someone in early stage Alzheimer's that is only available in clinical study right now. And so it's constantly changing, and each and every day there are more options for people with dementia. And so it allows them greater opportunity to explore treatment options that have the better effect in that earlier stage of disease. But most importantly, it allows the care team, the physician, the family, etc., to involve that person in the decision making about their future. They may be able to craft a bucket list and execute it. I knew a caregiver whose wife had Alzheimer's. And when she was diagnosed, fortunately, she was diagnosed early enough where she could still travel, make decisions, and she decided that her bucket list item was to visit every single national park in the US. And because her disease was detected early enough, she could achieve that goal. She could still travel, and she could accomplish that bucket list item. So there's a variety of benefits with early detection, and the diagnostic space and medical community is working on catching up to being better at detecting that early detection. So what might that look like? How is dementia detected and then the cause determined? Anyone over the age of 65 who's insured by Medicare is entitled at their annual wellness visit to a cognitive assessment. This is a quick, verbal, written kind of interview with your primary care doctor that might include being given a few words and asking to retrieve those, drawing a clock, being told a story to repeat that. And actually, one of our efforts in the state plan and our coalition at the state level is to ensure that those who are over age 65, so in that kind of age range, are receiving this test by their physician. Even though Medicare covers it, doesn't necessarily mean that physicians are doing it. In addition to kind of that simple cognitive assessment, someone may be screened for depression. They may have a close companion, someone who knows them really well, provide information on changes to the physician because they may see changes that the person doesn't see in themselves. There may be a physical exam, like a urinary analysis, to look for things other than Alzheimer's that could be causing the dementia. But there's a growing area of diagnostics that include other laboratory tests, brain imaging, such as a PET scan, and cerebral spinal fluid analysis that is allowing us, again, a collective us in the medical community, to actually detect the biomarker, the unique pathology of the disease, these amyloid plaques, tau tangles in the brain or in the blood. So this diagnostics are definitely rapidly evolving. You probably have heard of new and novel treatments, pharmaceutical treatments for Alzheimer's disease. And frankly, this has come with some controversy. Aducanumab, which was passed a few years ago, was the first disease-modifying therapy introduced to the market that was FDA approved. So this drug actually, with the proper diagnostic tool, a PET scan, to detect amyloid plaque in the brain, this drug was the first that could remove amyloid plaque and therefore slow the progression of disease. So just within the recent handful of years, we've had our first disease-modifying drug. Now, aducanumab has gone off the market, and there are now donanemab and Leqembi that do the same thing, again, with a PET scan that identifies amyloid plaque. They're able to reduce amyloid plaque in the brain and therefore allow someone to function a little bit better for a little bit of time. But right now, there are no treatments, medications that cure Alzheimer's disease. So if you see something at the pharmacy that says, take this and it will prevent memory loss, unfortunately, it's too good to be true. There are a small handful of therapies that are FDA approved, again, Leqembi and donanemab, that upon confirmation of amyloid plaque in the brain through a PET scan can change disease progression. And with clinical studies, this is changing every few months. And so there certainly is the knowledge that in years, in a few months, the treatment for Alzheimer's disease will look different. This is new because the therapies that have been used since the 80s to manage the symptoms of Alzheimer's, they were not disease modifying. The disease still progressed. They just helped someone function possibly a little bit better. So within the past few years, you've been hearing more about Alzheimer's treatments because it's the first time in the history of the disease that we had therapies that could actually change the course of that physical disease. Now, at this point, these are commonly administered intravenously. They're very expensive, even though Medicare covers them. But soon, we're expecting that disease-altering treatments will be available in a pill or a patch, and diagnostics other than a PET scan will be developed. PET scan is very costly, and there are many communities that don't have access to a PET scan. And because availability of these treatments depend upon that PET scan, it creates a little bit of a limited space and some inequities in access to these treatments if someone so chooses. As I wrap up, I'm just going to talk about the physical, emotional, social, and financial toll that Alzheimer's can place on families. And I say families as in direct families, but family of choice. So if someone doesn't have a spouse or adult children or cousins, they may have family of choice. We know that a large majority of caregivers who are providing unpaid care are women. And we know that about 1/3 of them are daughters. Many of these daughters, adult children daughters, are still in the workforce. They're still working. They're also raising young families. And so when someone says, well, I'm too young to worry about Alzheimer's, I often say, well, many young people are now becoming the caregivers to those with Alzheimer's. We know that compared to caregivers with who are caring for someone with other diseases other than dementia, we know that dementia caregivers report much higher emotional, financial, and physical difficulties and tolls. And that is because of that eventual need for 24/7 care and supervision. And so even though a certain number of people may have dementia, may have Alzheimer's, because of the impact on families, and particularly younger people who are still in the workforce and raising younger individuals, that is why this really is a public health issue that affects us all. I noted that dementia caregivers, in comparison to caregivers to those with other diseases, have higher emotional and physical and social burdens, but they also have twice the average out-of-pocket caregiver costs. The cost of someone caring for someone with dementia is very high. Dementia caregivers have higher levels of depression and anxiety. And so not only does this disease affect the person with it, I would say eventually someone with Alzheimer's may not be able to recognize that they have it at all. But then it becomes acutely aware to the caregivers, and they experience very high levels of anxiety and depression. Some signs about caregiver stress, I think, as libraries being such an integral part of providing information on Alzheimer's and dementia is great and important, and educating around the difference between kind of what is normal aging and what are those symptoms that we talked about that may be dementia. But it's also important to talk about the signs of caregiver stress. Withdrawal from friends and activities is a pretty significant one. So possibly someone caring for a parent with dementia always went to a book club, or always went to pickleball, or always went to a computer group, and then all of a sudden they stop showing up. And so the weight of caregiving can cause physical and social health problems on caregivers. Caregivers to people with dementia experience extreme levels of sleeplessness, Lack of concentration, particularly when they are providing that care directly in the home. Someone with dementia may be up 24 hours a day, up at night, and to keep that person safe from falling down the stairs, eloping out of the house, their care partner may need to stay up with them to keep them safe. So if you're a caregiver, it's important to talk to your doctor about the health issues that may be caused to you, but to also know that there are resources for caregivers, tremendous education tools that make caregiving easier, caregiver support groups, etc. Caregivers always should need a break, respite care. So, possibly asking a neighbor or another family member to step in so a caregiver can take a break or take a vacation is very important. There are also formal respite services and actually funding available to pay for respite that, as part of this state plan in Colorado, we're working to get information to the community on. It's important that caregivers take care of themselves physically and emotionally. Historically and statistically, a care partner to someone with Alzheimer's, they actually have worse health and a shorter life expectancy than the person with Alzheimer's disease because of the weight of caregiving. So taking care of yourself is really important if you are a caregiver or know a caregiver. Calling the Alzheimer's Association through our 24/7 helpline here. Someone will answer at 2 o'clock in the morning, Saturday morning, Friday night, etc., to provide one-on-one help, support, resources, and or visiting the CDPHE's website that lists a number of other resources for care partners is really important. There's a lot of help out there. This just kind of touches the surface on the why and what might be out there. Now, if you're concerned about yourself because you may have a family history like me, you may be getting older and noticing, goodness, my brain just isn't as sharp as it once was. I know when my dad retired, he said, my brain just isn't as sharp because I'm not using it as much as when I was in the workforce and using it in complex ways. Anyone with a brain, I would argue, should be concerned about their brain health. And just like those of us with a heart, all of us have hearts and brains, should be concerned about the health of both. We talk a lot about heart health, right? We talk about getting our cholesterol checked, what our blood pressure is, etc. But brain health is definitely a kind of a developing area, and it's because we know more and more about the brain through the research happening on Alzheimer's disease. So it's a little early to say doing X, Y, and Z will prevent the disease completely. We're not there yet. And again, if you see a product that says it will do that, it's too good to be true. But the science is telling us that there are habits that we can do that lower our risk pretty significantly of developing cognitive decline, so slight changes in our cognition, and lower our risk for dementia. So what are those things? The most important thing, the best thing we can do for our brain is actually take really good physical care of our physical health. Getting enough physical exercise, when we get our heart rate up, that actually helps the blood flow and oxygen flow from our heart to our brain. So physical exercise is actually one of the best things we can do for our brain. Eating right. So I'm never a fan of, just because it doesn't work for me, a diet that you do for 2 weeks and then you go back to what you used to do after those 2 weeks. So here we're truly talking about kind of lifestyle changes that are feasible to implement on a regular basis. The eating kind of patterns that have been studied the most include the DASH diet, which is a diet often used for the management of blood pressure, but also the Mediterranean diet, What these boil down to are probably what you can expect. Diets that are heavy in leafy greens, vegetables, fruits like berries. My friend and colleague JJ says, it's not that I've eaten my berries today, it's have you taken your berries? They have a lot of great antioxidants for the brain. Maintaining a healthy weight. BMI at midlife. So having a high BMI at midlife has been seen to be a higher risk factor for developing dementia. What's also important is to manage your numbers. So kind of another motivating factor to take control of maybe your blood pressure, if you have diabetes, your A1C number, and your cholesterol. Taking control of those numbers aren't not only good for your heart, they're good for your brain. Getting enough sleep has been shown to significantly lower the risk of dementia. I'm a great sleeper. I probably sleep too good, but I know a lot of older adults who have said, I'm an awful sleeper. I really have struggled to sleep. And they kind of tend to exist in the future without getting enough sleep. And they just say, I'll deal with being tired. But the science is showing that proper sleep, both in quality and quantity, is incredibly important for the brain, and particularly treating sleep apnea if that's present. Being or becoming smoke-free, we know tobacco use is bad for the heart, also bad for the brain. And staying in school, whether that's formal school or informal school, like going to your local library and taking a class, or using a different part of your brain to learn something new. I have a friend who has Alzheimer's, and she reports that upon a very, very early diagnosis, she started exercising, walking, 1 or 2 hours a day. That's a lot, I know. And also painting. She never was a painter, and she started painting. And she reports that those two things, along with diet changes, has actually helped her maintain her cognition. She feels that her brain is better taken care of. And that's someone who's already in the stages of the disease, but science is showing that it's true for those of us without symptoms as well. Protect your head. Head injury, after age, family history, genetics, and some of these other kind of cardiovascular risk factors, head injury is a pretty significant risk factor. And this is why this matters along the lifespan. Children should be wearing helmets. When I go to a rodeo and I see a bronc rider not wearing a helmet, those are all very concerning things that we can do. We can wear a helmet, whether we're bike riding, bronc riding, or skiing, can protect our brain. So protecting our head is very important across the lifespan. But this is also why falls and head injury and falls is another thing to kind of manage in older adults. Here's just an outline of the resources that the Alzheimer's Association provides. Our helpline is fabulous. At any time, day or night, someone who speaks English, Spanish, or over 200 languages can call that number. Someone will answer. It won't be me. I say I always will call back, but it is so reassuring to me that those in Colorado can call at 2 a.m. when they are so frustrated in their caregiving. Possibly their loved one is showing such high levels of agitation, they don't know what to do. They can call the helpline and get that support. We have a fabulous website, but more importantly, we are working very hard to expand and grow not only this education that I recognize is very high level and covers a ton of different things, but we have more in-depth programs. Programs like our 10 warning signs program. So that's a class that goes into those 10 symptoms in a little bit more detail and actually kind of talks through how to seek a diagnosis and work with your loved one or yourself to do so. We have our caregiver series that provides a deep dive into communication, challenging behaviors, how to actually physically be a caregiver, and what care options are available. And through the state plan, we are looking for partners in you all. And when I hopped on with Christy, I said, today is to me much more than a one-time conversation. I hope this plants a seed with the state library or your library wherever you are to either host, lead, or spread the word. So what we mean by that is you want to host. You want to host a speaker at your library on one of these topics. We can do that in person, virtually, etc. Or maybe you are an expert in aging and dementia, and you want to become a trained trainer as part of the state plan through CDPHE to deliver these programs. You could become a trained trainer to lead these programs. Or possibly you say, what works best for our community, our library system is we have a fabulous e-news, and maybe we just want to link the on-demand education center in our newsletter so you can spread the word. So those are really our three kind of opportunities to work together. But it's truly been a privilege to run through all of that with you. I'm proud I kind of stuck right within an hour. But my dogs, as they are barking in the background, have told me to hand it back over to Christy and allow time for Q&A.
Thank you, Kelly, and thank you, Kelly's dogs. I have a few questions in the chat, but before I put them out and ask them so they're captured on video, I did put just now a link to the state library page, the Colorado State Library page on adult services, the tag for the older adults and aging section. So there is quite a bit of information there, but also resources, including to the Alzheimer's Association and to a lot of the kind of studies and potential kind of programs and services that we can offer. Maybe just dream about them. I also put a link because Kelly mentioned the arts, and I would be remiss to not mention creative aging, which is an older adults arts education, like legit arts education program, series, etc., that many libraries have participated in, and will have, the state library will be hosting a webinar. Oh my gosh, I want to say it's April, but it's probably May, with Think 360, who is the state's provider of creative aging programming. Anyway, but I digress. I would like to get to our questions. So the first question we have from Elena is it anticipated that the number of people with dementia will also double or more than double by 2050? So that was on an earlier slide when you were talking about the trends of diagnoses.
Yeah, so that's kind of as we talk about prevalence, so amount of people with, I'll say Alzheimer's disease. Generally, we say double. We say it will at least double. One of the challenges with this data is we are relying, when it is Alzheimer's disease prevalence doubling, we're relying on specific records of Alzheimer's diagnostics. Up until about 5 years ago, 50% of dementia was never diagnosed or documented in a medical record. So dementia, meaning just those symptoms that could be caused by a number of different things, is harder to quantify because of underdiagnostic rates due to the challenges and hesitation by physicians to document and diagnose dementia. We're hoping to change that practice in medical care, where we see better diagnostic rates and documentation rates. And so there are some kind of data sets that you see that actually say more than double because of that. A lot of people think back to the 1950s when cancer, for example, was significantly underdiagnosed and not documented. Up until a few years ago, we were really still in that space with dementia and Alzheimer's, but it's changing giving us better data to estimate prevalence with population change.
Thank you. I think the ability and the availability of diagnostic criteria, diagnostic tools, and even the labels that we use is something that we've seen in many spaces, right? So changing and affecting or impacting the numbers that we read. So thank you for that. The next question we have is from our dean, and I hope I said that right. Have you heard anything about a correlation between siblings with Alzheimer's and Parkinson's disease?
Uh, Not necessarily. So with Parkinson's, I mentioned that Lewy body dementia is commonly associated with Parkinsonism. So some people will develop physical symptoms of Parkinson's and only have those physical symptoms for their lifetime. Michael J. Fox is a good example of that. However, Lewy body dementia is kind of this umbrella, whereas someone can develop cognitive symptoms first, or they can develop the physical symptoms of Parkinson's first, and then kind of within 6 months to 9 months, they converge, and it is more clearly Lewy body. I'm not as familiar with the genetic and family history predisposition for Parkinson's disease and Lewy body disease. And so I can't speak to that for certain. But with Alzheimer's disease, there is that kind of family history connection that is either due to just having a blood relative that has had it and or having a genetic predisposition. But both Lewy body, Alzheimer's, other forms of dementia, when we talk about lifestyle factors that can reduce our risk, kind of apply to all of them. And because family systems often live similarly at a particular part of life, there may be higher family history rates in certain families. But I can't speak to the Alzheimer's, Parkinson's connection because Parkinson's and then Lewy body disease as an umbrella are kind of different disease processes with different genetic and family history prevalences.
Thank you for saying that. I went ahead and put in a link in the chat for the National Parkinson's Foundation, which has a lot of public-facing information related to research, including things like diagnostic criteria and risks. Parkinson's is not necessarily genetic, and many environmental factors can play into creating situations and conditions in which Parkinsonian symptoms arise. That is just something I happen to know. So
I
thank you
think
for that.
this is brilliant because librarians you're great with finding information. I wouldn't
That's
have
the
thought
gig.
of I thought of that. The other thing that I think of is actually the Lewy body dementia association. There's actually Lewy body is one dementia that we're finding out more and more than ever before, and it's believed that we've overdiagnosed Alzheimer's and underdiagnosed Lewy body. So I posted that in the chat too. That's a great additional resource.
Thank you. We have one more question that's been put in the chat, so I really want to take this moment to invite others. Kelly is with us for another 15 minutes, and she's happy to answer questions throughout that time. So let me go ahead and read the next question, which is Jacob's question. Is there evidence that Alzheimer's progression is linear or progresses differently in different people?
Good question. So younger onset Alzheimer's. So when Alzheimer's symptoms, dementia symptoms present before age 65, generally, not always, can progress more quickly than later life Alzheimer's. It's kind of a different disease process. One of the reasons for that is not all, but some younger onset is due to one of those deterministic genes that I mentioned, where these deterministic genes kind of run through families, where if someone has this gene, there's a 99% chance they will develop Alzheimer's, likely in their 40s. These families receive a lot of media attention, and so people often think it's more common than it is. But younger onset with that kind of genetic deterministic predisposition can progress more quickly than later life Alzheimer's disease. What changes the progression is when is someone diagnosed? Is someone diagnosed maybe in the middle to later stages where we think they lived for 4 years with Alzheimer's because that's how long they've had the diagnosis, but they've had all these changes before. And so with someone's diagnosed is why there's such a wide range in life expectancy for someone with Alzheimer's. Additionally, everyone's brain is different. Intelligence varies significantly. So there has been work that shows that people with more cognitive reserve may have a longer experience in the disease because they are more able to compensate cognitively. What also matters is someone's overall health. So what other health activities are they doing that are not only benefiting their physical and cardiovascular health, but also their brain? The last thing that might impact someone's kind of progression of disease is actually the quality of care that they're getting. Something as simple as great toileting and bathroom behaviors to avoid infection and thus avoid hospitalization can cause someone a better quality of life with Alzheimer's. So it's hard to say and quantify progression, and the linearness of it is so personal and due to someone's unique abilities and kind of what their cognition has looked like over their lifespan. That varies widely in families. My sister can do Sudoku, I can't. And so her cognition, her cognitive health is different than mine, right? And so there's kind of a variety of things that impact that.
Thank you. Molly put a question in the chat that I think is probably a question for me. So, but please, Kelly, answer or give some input if you can. So Molly's question is, what are library programs you've seen or are dreaming up for supporting people with Alzheimer's and their caregivers? So I'll mention again that link to the State Library webpage, the specific like kind of little area for older adults and aging. Some things that I think are great. Reading to Connect is exactly what it sounds like. It is a kind of envisioned as a kind of peer reading program. It would probably be a little staff intensive. It requires some of their materials. It is absolutely affordable for most libraries with or without grants. And that is this idea that social connection through literacy and very specific texts written for folks who have difficulties perhaps engaging with traditional text at this point in their lives. I would encourage you for the Maternally kits, which are these like reminiscence kits. You can build and make kind of your own. Arapahoe Library District does this, and they inspired me to make some that I take on trainings, just to kind of give an example. But Maternally kits, they again on there, again affordable. They can be library collection items and can be used in programming. Creative aging is, it could be, depending on how you are able to connect with the teacher artists, can be maybe cost prohibitive for some folks. But the good news is that there's a lot of local, I say this in Colorado, and I'm primarily speaking of the Front Range. So apologies for thinking outside of that. There are some local art organizations. Now I'm thinking, I can't like, it's Accessibility Arts in Denver, and they do a bunch of programming that's a little more broad and beyond, that could also be very helpful in just partnering and seeing that those folks come into your libraries. I'm very encouraged by some libraries hosting caregiver kind of programs. Caregivers, my mom is a caregiver. Caregivers forget maybe that they are also existing in bodies and also have their own brains And a lot of times we forget that. And it's been interesting to see libraries having like how to be a caregiver programs, really like 101 stuff. Not everybody knows what an advanced directive is. These are conversations that folks, perhaps not even with memory care needs, need to be considering. Broomfield Library, Garfield County Library. So these are two Colorado library systems, have some excellent, excellent programming and series in partnership with Garfield has like the local coroner's office. Broomfield has any number of city, because they're city libraries, city agencies, very robust partnerships with those senior, or tend to be, and I'm going to put that in quotes, senior health services offices. Time Slips by Ann Basting is an excellent resource. Ann is fantastic. Follow her on LinkedIn, follow her work, and really kind of explore the opportunities for engaging folks who have memory loss in the memory of who they are and their lives. And they are alive today, right? So also engaging, like enriching the daily life. I will put in the chat again. Wait, will you post? Yes. Will you post the books link? I'm not sure, Juliet, which books link. Oh, Read to Connect. So I'll put that in there. Yeah. So it's not books. So you'll see. So those are just a few of the things. I also want to point you to Denver Public Libraries because Amy Delpo is the head of, like, she's a supervisor of the older adults. Like, I don't want to call them a department, but they might as well be. Amy is like a leader in this work. I've literally nominated for her for awards. She is amazing. Her ability to connect with memory care in particular, and all of the kind of, not just the research, but the resources out there to connect our library spaces with the kinds of things that we can provide for our patrons, whether or not they have memory loss or they're just, getting old, right? Like, it's really, really rich. She's such a great resource. So I connect you to her too. And I'll go ahead and put some of the individual links in the chat. So hopefully, Molly, and the rest of you in library land here, get something out of that. And of course, I will share these links in the follow-up email as well.
And Christy, may I just add to that? Because it always boils down to funding and capacity, right? For all of us and all of our organizations. Our hope at the Alzheimer's Association, our work with the state plan, is to share what we're doing that y'all can take advantage of for your patrons at no cost and very little work. So we have over 100 support groups for caregivers across Colorado. Some of these are virtual, some of these are in person. It could be as simple as including this listing of these support groups in your e-communication or in your newsletter. And so you don't have to feel like, oh goodness, I have to build something up from scratch. The other thing that I think is really important is, particularly with people being diagnosed earlier, there may be people living with dementia participating in your existing programming. And so it's also important to rethink, we might not always need to create programming for people with dementia, but we can offer our programming to people with dementia that we're already doing. And so I think that's also kind of just another angle to think of it. Memory cafes, Dementia Together in Northern Colorado. I saw that post. Yeah, fabulous resources. But we're also at a time where if you're having a lecture on horticulture, why can't someone with dementia go to that, right? And so that's kind of something that's come to my mind a lot recently too. And I'll post, and if you can share it, Christy, in the follow-up email, that support group listing. Because there might be one right next door where you think, oh goodness, we don't have to create a support group, we can just share this one. And ditto what you said about Amy Delpo. Oh, you're muted, Christy.
when I go between two different mics, I forget which one to mute or unmute. Jacob mentioned that Alzheimer's Association partners with their libraries for caregiver support groups, and that's wonderful. Again, Alzheimer's Association definitely has those resources, caregivers of all types of folks, right? And care partners too. I think some of us forget about that. Sandra, who's out in Vail, I might be wrong about that. We have worked with Dementia Together, and they have memory cafes. So I was remiss to mention that. And so I went ahead and put memory cafes links in the chat as well. I also put a link in the chat because I didn't know what day it was. April 10th is the webinar that we're doing. For those of you who participate in the collaborative summer learning program, and most of us are adult folks here, so we don't really with the youth services, but the theme this summer coming up, so 2025, is like an arts theme. It's Color Your World. So I asked, is there a way that we could do engaging programming through arts for our patrons who are older adults during the summer? Why not, right? And so even if you don't want to, quote, buy into the program because you can't afford it or don't want to, there's absolutely some skills and ideas that you could tap into that would be very useful, perhaps. Beth writes, the Boulder Museum of Contemporary Art does a program called Spark for dementia patients, yes, and caregivers, and loves to take it out to libraries. Yes, they do. Boulder is Boulder, but if anyone who lives in Colorado knows, Boulder is Boulder, but it's also a bunch of cities and towns that start with L and are all in this area. So really reach out to maybe not just your city, but the larger kind of broader area around you. They will travel. I may have missed a question, so let me scroll back up. Any other questions? We have a minute, but all right. So I'm going to stop the recording now. I'd like to thank everybody for showing up.